Okay, so good morning, everyone, and welcome to this Global Digital Health Forum event. This is a panel discussion called Integrating Data from Digital Community Health Programs into Broader Government Health Data Systems to Maximize Impact. It's hosted by us at D3 International. So D3 International, we are a global digital health organization operating programs in Tanzania mainland, Zanzibar, Malawi, and Zambia. And we are fortunate to be joined today by some of our partners from Tanzania mainland. So this is Apoteca, where we will have Angel Dillip talking to us about using data for health impact. We are also expecting to have one of our partners from the Zanzibar Ministry of Health joining. So hopefully we'll have Dr. Salim Slim, who is the Director of Preventive Services from the Zanzibar Ministry of Health. He is traveling at the moment, so he's actually part of a delegation that's traveled to Ghana. So hopefully he will manage to join us a bit later, maybe after the first presentation. But for now, I think we will start with Angel's presentation on data use for health impact. Then there will be another presentation from myself, where I'll look more at the technical and data governance aspects of integrating data into government systems. And then, as I said, hopefully we'll be joined by the Director of Preventive Services from the Ministry of Health. This session probably will last around 40 minutes or so. As we're presenting, if you're in the audience, you're very welcome to post any questions that you might have or any points for discussion. We'll be very happy to receive them and have some discussion at the end of the presentations. But other than that, I'll hand over right now to Angel. So thank you very much, Angel, for presenting on behalf of Apoteca. If you'd like to start your presentation on data use for health impact, the floor is yours. Thank you.
Yeah, thank you so much, Stacey. As you said, my name is Angel Dillip, and I'm project lead for the Apoteca Access Initiative. It's an NGO that works on strengthening pharmaceutical and health systems in Tanzania. So today I'm happy to talk to you about the data use for health impact. And I'll speak about the project that we are implementing together with D3 International. I'm trying to see my slide. I can't move my slide. Yeah. So I'll talk about the AfyaTech program as a case study for this particular presentation today. And I'll talk about how are we using our data in terms of improving health impact in Tanzania. So the AfyaTech program is a digital health intervention that links 3S system actors at community level. And these are community health workers, health facilities, and drug outlets. So as we both know, the health facilities are in charge of both community health workers and the drug outlets. But again, the linkage among these three actors is not strong enough. And of course, the health facility have somehow a link between it and the community health workers, but the link between health facility and the drug outlet is very, very weak. So because of this, then there's a lot of delays in terms of accessing treatment and death happening at the community level. So AfyaTech program came with an intervention to strengthen these 3S system actors by using a digital platform that links them together so that they are helping a client as this patient navigates through different points of care. So the community health worker has been empowered with a decision-making application that allows them during their household visit to see a client who is sick, assess his or her health condition, and in case it's minor illness, then this patient is immediately linked to the nearby drug outlets. But in case there's a danger symptom, then this client is linked immediately to the health facility. So the same happens also at the other level. And of course, once this patient arrives at the health facility, then the health facility staff who receives this patient, they are able to see whether what are the danger symptoms that this patient were assessed at the community level. And the ones who provided the referral, community health workers in ADO, are also able to see whether their clients have been arrived at the destination. So our key intention is improving maternal, child, and adolescent health In Kibaa, we're working the 2 districts of Pwani region in Tanzania, and the intention is to actually improve prompt treatment and care for these 3 target groups: mothers, children, and adolescents. So this program has been in Tanzania since 2020. There was still the project ends in this year, but again we have potential for funding, continue funding until perhaps 2026. So the AFETEC program is implemented by a number of consortium. We have Afoteka as the lead, together with D3 International. As I said, our expertise on maternal, child, and pharmaceutical strengthening. In D3, of course, they are bringing in their digital interventions in terms of ensuring that these 3 system actors are able to talk to each other. We've been working with the owner. This is a digital platform company which are based in Kenya in terms of technical support in preparing this digital platform. But we've been also working with the Institute of Tropical Medicine in Antwerp, Belgium, and they've been assisting us with the monitoring and evaluation component of the program. We're also working with Inspired Ideas. This is a small local Tanzanian organization with the expert on artificial intelligence. So we've been also implementing a bit of artificial intelligence as part of the architect program. Previously working with Simprint, but currently we're still not working with they're still not working with them for now since last year. And of course, we've been working closely with the government of Tanzania, and this program is funded by Foundation Botna, who are based in Switzerland. Yeah, so the data use that I was talking about. For the AFETEC program, we have data used across different levels of the government, but also at the community level. So as mentioned before, we have these 3 system actors, the community health workers, the drug outlets, which is called ADO, and the health facilities. So these 3 entities are able to share data across their levels to understand what's going on with each other. So, for example, what the community health worker does, the referral then to the health facility is able to see what is expected from the community, but also it's happened to the adults as well. But again, the community health workers have their supervisors who are stationed at health facilities, and these supervisors are able to lead for the lead time to monitor what is happening with the community health worker. Sorry, I've heard that people cannot see my screen, right?
We can see your screen. I think they are requesting if it could be a full screen instead. So yes, we can see your screen and your next slide. So we want to see only the slide you are talking about. I think it should be one of the options at the bottom of your screen. If you could move.
The bottom of
yes,
the
yes. If you click on that, let's see. Under it comes back to the same option. Could you please click on display settings?
On there?
Okay.
Setting.
Yes, here. Okay, click on that.
Yeah, I think that's where I was. Perhaps there's a challenge in terms of sharing.
Yes. So display settings at the top of your slides. There's show task and display settings. Click on that. So we can click on that. Okay, so I think we'll have to bear with the size of your screen at the moment, and I think we can proceed with what we have so far.
Okay, sorry for that. Looks like. Let's see. Yeah, so as I said, the community health worker have their supervisors who are stationed at the health facility. They're also able to assess what is going on with their community health workers and monitor their performance. But also with the district health management teams that are stationed at the district level, we build their capacity in terms of understanding the architect dashboard so that they are able to get into the dashboard and trying to see some of the indicators at the community level and make decisions. For example, at the district health teams, they're able to understand using the AFETEC dashboard the number of pregnant women that are being registered within the community, so that they're able to plan their resources effectively. But also they're able to understand the danger symptoms and signs that are actually recognized by the community health workers and the adults. But they're also able to see the registration status, because prior to starting the program, we need to register all community members in the 2 districts that we're working with, so that they're in the system and they can be seen whenever they go for treatment. But also they're able to understand the family planning services that are offered at the drug outlets, to understand actually what is mostly preferred by this adolescent. And most important is for these adolescents who are pregnant, who are getting pregnant before 20 years of age, who mostly prefer to attend at the drug outlets. So these district health teams are able to understand what are the preference for these adolescents, and why, for example, they're not coming to the health facility on time, and to see how best they could monitor. Also, we've been working closely with the government throughout the designing of the program. So the Ministry of Health has been participating in the system design of the AFETEC. The requirements, of course, one of the requirements was for us to use the open SRP system, which is their recommendation. So the AFETEC system was built within the open SRP platform that was recommended by the government of Tanzania. So they've been participating even in the testing and the deployment of the system, but also in the field activities. They've been also very influential and helpful in terms of reviewing our system, giving us recommendations. They're participating in the district meeting, but also at the district and regional level. They've been mostly involved in the co-designing of the AFETEC system, both at the council and at the regional, but they're participating very much in terms of the sensitization of the program, and they're involved also in the training of trainers, because we have to train all these users so that they are able to talk to each other, the community health workers, the drug outlet, and the health facilities. We have to bring them together, train them. What do they need to do in terms of understanding the AFETEC system, but also speaking to each other so that they're able to assist these one clients. We also have a strong supervision and follow-up team at the district. We have the supervisors, as I've said, we have identified the champions within the supervisors themselves. These council health management teams are also very helpful. So we have almost weekly touch-base meeting with the district health teams between Aditri, Apoteka, and them to understand what is going on. So they are getting to their dashboard and understanding the challenge, and don't conduct some kind of follow-up and supervision activities with the key intention of improving the performance of the users of the system. So this is just an example of the demo of our application that is used by the community health worker. So you can see this. This is the pregnant women with 39 weeks pregnancy. So the community health worker is able to conduct a number of activities, including assessing the danger symptoms or doing some kind of follow-up visit for these pregnant women, do some kind of counseling, also malaria prevention is also another component. And on the right side, you can see some of the danger symptoms, danger signs that we assess through using their AFETEC smartphone embedded with the applications. And of course, as I said before, in case there's a danger symptom that is identified among the pregnant women or any other target group, then a referral is made straight to the health facilities. And this is another dashboard that the health facilities, for example, once the health facilities receives the referral, then of course they are in position to see what are the reasons for this referral. And they are able to understand the danger signs that actually were recognized either by the drug outlet or by the community health workers. And they're able to see, for example, who made this referral, whether it's the drug outlet or the community health workers. So from there, then that's where the AFETEC system ends, and it's up to the health facility themselves now to take this patient and continue with the treatment. But again, the community health worker and the adult are able to get this notification that the client is alive, and also do some kind of follow-up at the community. So the next slide, these are just the quotes from the government authorities just endorsing the AFETEC system. And of course, the first one was this Ministry of Health staff, where they very much appreciated the AFETEC system, and they said this is the first system that has actually connected private drug shop, community health workers, and the health facility. Because we have other system that are connecting the community with the health worker and the health facility. But the unique part of AFETEC is that we're bringing in the private sector, which is the adult, in terms of bringing them together so that they are able to support the clients, considering that the drug shop are also attending a good number, reasonable number of clients in the community. Yeah, the other quote was by the second quote is by the registrar of Farmers Council in Tanzania. I think he also very much support the AFETEC system, and this is when she met with the other owners in the dispensers, or the drug outlet owners in the dispenser, trying to sensitize them and encourage them to continue using the AFETEC system, so that in future we are in position to scale this program elsewhere. I think the third quote was also from the district medical officer in Kibaha, who also shifted to another area. But again, while there was still recognizing and appreciating the effort of the AFETEC system in terms of addressing maternal and child health challenges, but also referrals from the community to the health facilities, because that's where the challenge is. The community health workers are seeing patients, but in case there's no digital system, then these patients are not, there's no means of tracking them so that they arrive at the health facility on time. And of course, the last quote was from the district medical officer, who actually, and I like this quote much because she said that the AFETEC system, the dashboard, is actually more than the census itself. And because it has a lot of information that can't be found anywhere else. So even some of the projects that comes to Kibaha, they're also using the AFETEC dashboard in terms of doing this sampling for the study that they want to do in the program area. Yeah, so here's also an example of how we can see the supportive supervision taking place in the district. We have these community health workers, and then we can see, of course, how are they doing their visits. For example, you can see the first one with Ansila Kimalo. You see that she has done almost more visits for the adolescent compared to others. So this is just real-time monitoring of what is happening. But again, we do pay the community health workers based on performance, based on how many visits they conduct at the household level. So on this table down here, you can also see the example of how we do this kind of payment based on the performance, based on the visits that they are done. But as I said earlier, this dashboard are tailored supervisory support in the sense that the community health worker supervisors are able to assess, but also conduct any support that is needed in terms of improving the performance. So again, this is an example of the program monitoring. For example, currently you can see that we've registered almost 89% of the communities in Kibaha. This is 228,000. And almost 67,000 also have been registered. 6,000 pregnant women are registered in the systems. And currently, I think for the past three or 4 months, we have almost 1,000 pregnant women registered. And we have more than 24,000 adolescents being registered in the system, 41,000 children, but also postnatal women. And since we started the program, total health facility referrals, I think, are more than 30,000 now. And these are facility referrals that have been provided by either community health workers and the adult to the health facilities. But also the same at the health facility that have been issued at the adult levels, the health facilities, we have, I think, more than 3,500 referrals made at the adult to the health facilities. And you can see here on this pie chart that of course for the health facility referral, we have more of adolescents, but for the health facility referrals by drug outlet, we have more of children. So the number keeps on changing based on how they see these clients. And see, I think once there. So for the next steps, we are planning to integrate the architect system with the other government the health management information system, particularly GOTOMIS, so that we're able to get this complete care pathway. Once the clinical office assistant at the health facility is able to understand now what did this patient receive at the community level, what counseling was this patient receive through the community health worker, was he given any kind of medication at the drug outreach prior to arriving at the health facility. That's the plan that we have for the next phases. But also we've been discussing about how do we do the data storage and local hosting at the government, and ensuring that we have, of course, the data governance plans. So these are all next steps as we continue to solicit funds from the donors to support the architect expansion. So that's it. Thank you so much for listening, and we apologize for the screen sharing challenges. Thank you.
Thank you very much, Angel. Thank you so much for that very informative presentation, telling us about the AFIA-Tech program and describing all the different types of data that are collected and how so many different stakeholders can use that data. If you're in the audience, just as a reminder that you can ask any questions that you might have in the chat, and then we will get to them probably at the end of this session. But for now, we are very fortunate that we have been joined by Dr. Salim Slim, who is the Director of Preventive Services at the Zanzibar Ministry of Health. So, Director, welcome to this event, to this panel presentation on data use for the Global Digital Health Forum. We know that you're very busy and you're in Ghana at the moment with the Minister of Health. So I think for now, I'll pass over the microphone to you, Dr. Salim, for your comments about how the Zanzibar Ministry of Health sees data and any thoughts you might have on the topic of data use within the health system and the Zanzibar Ministry of Health. So please, Director, the floor is yours. Angel, if I could ask you to stop screen sharing, please.
Thanks very much, Tracy. I'm really grateful to be given this opportunity to speak on behalf of the Minister of Health in Zanzibar in relation to this very important and sensitive issue in public health. Zanzibar's health system rely on data to allow us to guide our way in delivering the best healthcare service. D3, for example, has been a major player on helping us facilitating this platform from the analog mode that we have been adopted for many, many years. Data capturing has helped us to really understand what is a contextual problem in our health system, especially in the area of maternal mortality. And probably it has been the cornerstone on allowing us to find a way out of this problem, which is one of the best indicators on health system sustainability. We do have a variety of platforms in receiving data, but regardless on how they come along, it's better they become centralized so that the government can able to access it and when it's needed. And that will enable us to see where the problem is and deliver immediately public health response. So adopting this data to the government now will allow us from the central level to see things from multiple eyes and able to deliver the public health response needed to remove whatever the situation is affecting the society. So I am a great believer that this innovation will be by all means be one of the most important components in our health system strengthening mission and vision as needed by our minister and even our president in Zanzibar. So I want to thank you all for giving me this opportunity to come and join you in this matter. I'm currently in Ghana, try to seek way on adopting different modality on what Ghana has done in terms of their level of success, and then using the same modality to see and fit in Zanzibar context, again for the same reason for health system strengthening. Here in Ghana right now, we are doing community scorecard, which is another area where data have been used to allow community ownership to make their own choice on what is needed in their local context to improve their health and well-being. Again, we are trying to adopt the version of health information using technology as a way to allow us to make the right choice and change policy where is needed. With that being said, I will leave this the chair back to you, Tracy, to continue, but we will stay forever grateful for your input, and I will appreciate your continued collaboration in making sure that using data to make sure the service that we're going to render to the public is going to make sure is equitable, accessible, and touching the most poorest and most underserved, and therefore no one should ever be left behind. With that being said, thank you very much, and I'm looking forward to continue collaboration with you. Thank you.
Thank you very much, Dr. Slim, and thank you for your comments about how the Ministry of Health is committed to using data as a means to drive forward universal and equitable health coverage for people in Zanzibar. And it's great as well that you're in Ghana right now and that you're managing to learn a lot about how things are done in a different country in Ghana and bring some of those learnings back to Zanzibar. So thank you, Dr. Salim, for taking time out of your busy morning to share your thoughts with us. I'm just going to see if there are any questions at the moment. So, as I said, we'll leave.
Thank you very much. And I'm going to come out because we are in the field work, but I really wish you a successful brainstorming Zoom link. And if there is anything, whatever it is that our government can play to create enabling environment to facilitate this important public health innovation, please get back to me, and I will find an immediate way to solve it using my capacity as a director of preventative. Thank you very much.
Thank you, Dr. Slim. Thank you. I appreciate your time. And so, as I said, we'll move on now to the third presentation, and then we may have a few minutes at the end in case you want to have any questions or discussion. So our third presentation is actually going to be myself presenting. I'm going to present about the technical and data governance considerations regarding integration of community health data into government systems. So let me just share my screen. Yeah. Okay. So just to begin with, maybe I'll just say a few words about why we are even talking about integration. So this panel presentation was about why it's important to enable government stakeholders to access data from programs such as digital community health programs, and for that data to be integrated into a central system. And the reason that we are discussing this topic is because what often happens is that health data in many health systems, many countries around the world, it's often siloed into separate silos. So that's because data is generated from many parts of a health system. There can be separate systems for individual health programs, so such as a malaria program, HIV, TB. These programs might be implemented by different partners, and those partners might build separate systems for each of those programs. And then also there are many different functions within a health system. So in the green boxes, you can see functions like human resources, finance, logistics management, drugs and equipment. And each of these functions can also have a separate system, a separate data system for that particular function. Then, as I've mentioned, different partners, implementing partners, when we're working with governments, we might often build systems using our own choice of tools and data platforms. So there isn't one platform that everyone everywhere uses. There are many different ones. And so everybody might be using different technologies and tools. And so that combination means that health data is often fragmented and siloed. And the problem with that is that when this data is so fragmented, it's hard, if not impossible, to combine data sets together, and that limits the utility of each data set. So, for example, you might be able to access data about one particular program, and you might observe that program is underperforming in a certain district or region. And you might wonder, is that underperformance because of inadequate staffing or human resource but you might find you can't actually access that data about staffing because that human resource data is in a completely different system that you don't have access to. And so what that means is that users can only analyze data from individual programs or system components, but you can't have visibility across the entire health system and see how all the components are fitting and working together. Each data set often can only be accessed by a few people, depending on who is running that program and how that system was set up. Because there are so many systems, there's a lack of visibility into what data is being collected across the whole health system and how it's being used. And then when there are so many separate systems, there is an unnecessary amount of data management that's created because you're now having to manage so many separate data systems. Therefore, if we want to maximize the impact of data, we have to bring these separate data sets together, and that's why we require what's called integration and/or interoperability. If you're not familiar with these terms, then what integration means is that data from multiple systems is, in quotation, it's translated into the format of one system, and then all that data is incorporated into a single system. Whereas interoperability means that data systems are designed to communicate with each other. So they can sort of talk to one another, they can transfer data between these different systems. And in reality, it might not be possible to integrate or interoperate all the separate data systems together because there are so many different data systems with so many different functions. But it should be possible at least to integrate, for example, service delivery data from all programs together into one system. And so we're concentrating on the integration of facility level data and community level data. And the situation here is that many ministries of health use DHIS2 as a standard data collection and reporting platform for facility data. So that's kind of standard across many countries, many countries and governments for facility data. However, community health systems are often built using completely different technologies and data platforms. So very occasionally, I think DHIS2 is used nowadays, but more often there are these other tools called, for example, Community Health Toolkit, ComCare, OpenSRP, and these are sort of fairly standard tools nowadays for building digital community health systems. So you have these two sort of separate sets of tools and systems. So on the left, as I said, facility data, most governments and countries now will use DHIS2 as standard, whereas on the right, the community health data uses a completely different set of tools and platforms. So for example, in Zanzibar, we're using Community Health Toolkit, CHT, and then our data platform is a commercial platform called SciSense. However, everyone is now realizing the importance of integration and interoperability. And because of that, it's now becoming easier to integrate digital community health data into DHIS2. So what that means is that this sort of green circle in the middle of this diagram, this is what we now consider to be the central data system, that's DHIS2. And as standard, we have data from public health facilities going into that DHIS2 system. We can also have data from private clinics now going into that system if we work with private care providers. And now we can also relatively easily take data from community health programs and also feed that into this central DHIS2 system. And if you want to see sort of more detail about exactly how we do it and how we do it in Zanzibar. So what happens in Zanzibar is that in the community health program, community health workers or CHWs, they do household visits to deliver health services and health promotion to their neighbours. And during those visits, they collect data about their clients. And they collect data at the community level using this tool, which I've said is called Community Health Toolkit, CHT. So that's via a smartphone app. All of that data from the community level, this is processed and stored in a database, which is the community health database. And then what happens then is that nowadays there are quite a sort of number of tools and techniques that make it relatively easy to extract data from our community health database, transform it into a correct format, and then push it into the Ministry of Health's DHIS2 system. And so what happens in Zanzibar now is that data is being transferred to DHIS2 on a monthly basis. So every month, data from the community health program is being transferred into the Ministry of Health central DHIS2 system. The advantages of this are that community level data complements facility level data by providing visibility into the health needs and health outcomes of people who do not or cannot utilize health facilities for any number of reasons. And this is especially true in lower middle income countries where there is a shortage of health facilities and or health workers to meet the needs of the full population. There are many people who aren't able to or choose not to access services and health facilities. Secondly, because we're incorporating the data into one system, health system staff only have to access and use that one single system, DHIS2, rather than having to access a second system specifically to access the community health data. And then because DHIS2 is already a standard platform for the Ministry of Health in Zanzibar and for many ministries of health in other countries, staff are already familiar with it, so they don't have to learn how to use a new platform, a new set of tools. Switching on now to a sort of different set of considerations. So we've talked a bit about sort of the technical integration, and I'll have a couple of slides now about data governance considerations. So when data from one system is integrated into another system, we have to think about the governance of the data. And the term data governance is used quite broadly and quite widely nowadays, but what it means in the context of health data that we're working in is that it's the practice of ensuring that data can be used effectively by the right people whilst protecting individuals and communities' right to privacy and agency. It's a very interdisciplinary practice requiring both technical measures. So for example, setting up password protection or firewalls and other IT security measures. But alongside that, it also requires human judgment. So in the end, humans have to make decisions such as what can the data or what should the data be used for and what should it not be used for, who should be able to access the data and who shouldn't be able to access the data, and so on. And just sort of a very brief list of some key considerations for data governance would be who can access the data, what can the data be used for, and what security measures are required to adequately protect the data. What can sometimes make it a bit more complicated is that if we consider community health programs, then there are sort of different types or different levels of data that are collected, which I'll explain. And these different types of data have to be treated or governed according to their level of confidentiality. So, for example, on the left-hand side, what I'm showing here is an example of individual client health records, which are collected by community health workers when they conduct their household health visits. So these are health records about individual people, therefore they're highly confidential and access needs to be highly restricted. So at the opposite end, on the right-hand side, this is what happens once you've taken those individual health records and you've done some processing and aggregation, and you've created some aggregate indicators, maybe at a district or regional level. So these are indicators, they don't contain information about any individual people, so they're low confidentiality, access doesn't need to be so restricted. And then in between these two examples, these extremes, there's a spectrum in the middle of different data types, which are providing different amounts of visibility into individual people's health versus more aggregated or more anonymized data, which contain less or no information about individuals. And so all of these different data types, the way these data types need to be treated and governed, that has to be taken into account during the integration process, so that we ensure that, for example, adequate access control restrictions are put in place for each type of data, and that is taken into account within the integration process in terms of whatever systems and tools that we're using. So a final slide on this is that data governance is often considered as an afterthought. And so sometimes people think about it only after a data system has already been set up or after a system integration has been completed. But actually, you should be thinking about data governance being developed and implemented at the same time that a technology or data system is being developed or that an integration process is underway. And so in Zanzibar, we're working with the Ministry of Health here, and they recently, earlier this year, created a data protection and sharing framework. So we can use this framework and make sure that when we're integrating data from the Digital Community Health Programme into their central DHIS2 system, that integration is compliant with this data protection and sharing framework. And remember that just like we invest in building people's capacity to use data, so Angel's talked a lot about that in her first presentation, we should also think about how to increase stakeholders' capacity to ensure that data is used ethically and responsibly in line with data governance best practices. Okay, so that's my last slide. So thank you for your attention. Let me just stop screen sharing. And I see that we have a question from the audience. So thank you for that question. That question is coming from Patrick or Pio Wheely, and he asks, do they have a fragmented system in other sectors or other health departments, and how are you dealing with that? So Patrick, I think the problem of, so the short answer would be, do they have a fragmented system? Yes, I think health systems are often fragmented because, for example, the way that, say, funding is allocated is that funding is often allocated to individual programs. So, for example, one donor might want to fund a malaria prevention program, and someone else might want to fund the TB program, and somebody else is interested in NCDs. And that sort of, I think, funding in silos and resource allocation in silos to individual programs and not so much to the health system as a whole leads to fragmentation of the system. So maybe your question is sort of like, does the fragmentation of the data reflect the fragmentation of the system? And the short answer is probably yes, that is the case. And then how are you dealing with that? So I think the way to deal with that is that it's not for any one partner to be able to solve that problem. And also it's a challenge for governments when different partners and donors are coming in with sort of their own specific areas of interest, as I said, regarding specific programs or specific functions like HR or finance. And I think it's very much for the global health community as a whole to think about how we begin to join up all these different fragments and to think about health systems as a whole, not in just individual health programs or individual health functions. But for that, I will open it up to, I don't know if Angel, you have any ideas or comments about this question as well. I just want to invite you to give any thoughts if you have any, as well as anyone else in the audience. If you have any responses to that question, do feel free to post them in the chat.
Well, thank you, Tracy. I think you've said it all. I think the challenge is still the fragmentation because of these different priorities, and then because they don't have funding, which is silos. So that's why we actually think that there's a need to bring this system together and do away with this fragmentation. So I think you've said it all well, and that's what we wish actually for the coming phases of our program, but also the government is now actually seen this concern, and they've advised on having these programs in one platform, like the one we're talking about, the Open SRP. I think this was the government's recommendation, that there have been a lot of programs, everyone coming in with their specific program. That's why now we recommend that everyone who wants to do the community digital programs should now use the Open SRP. So currently we have we're participating in the national working group on community digital systems in Tanzania, where we have a number of programs and projects working on the community level using the digital platforms. So we are discussing a number of issues, including how do we bring together different projects so that we are able now to integrate, having the single system that can actually bring in all the different project areas together using the Open SRP system, for example. So yeah, we are happy that these things have now been taken up by the government. And going forward, I think all other partners will be working on the community digital platform need to join this work in the existing national working group so that we're able to talk together. Yeah, so that's it.
Thank you, Angel, for that extra detail. That's very good context to know. Then we have another question from George and Bevy, who's asking, how did you manage to convince the government in the process of integration and sustainability? So what's actually really good is that I think, like in the case in Zanzibar, at least, the government want integration. They want interoperability because they themselves know that it's very challenging to try to manage all of these multiple different systems. It adds extra overhead to them. They already have sort of very limited resources, limited staff, and all this extra overhead that comes from having these multiple separate systems isn't very beneficial to them or to the health system. So that push for integration actually comes from them. So they actually at the very early on requested that when we were setting up the digital community health program with them, that they would want that data integrated into DHIS2, and they requested that quite early on. And they've actually also made developments recently in the creation of what's called a health interoperability layer. So this is sort of software or platform, sort of a technology layer that will enable different data systems to interoperate with interoperate with each other. And so the government actually doesn't need convincing about this. And I think that's probably not just true of Zanzibar, but I suspect it's true of a lot of ministries of health in many countries, that the preference is for integration and interoperability because everyone realizes it's beneficial to pretty much everyone. And then also you mentioned sustainability as well, George, and I think this is part of it as well, but like people realize that if everything is integrated into one system or as few systems as possible, this is also beneficial for sustainability, because in terms of how much does it cost to maintain that single system, it is far easier to sustain one system than it is to sustain 10 separate systems. That's George's question. The comment from Pendo Said in the response to Patrick. So just in case anybody is not reading this, like Pendo says, in Tanzania, data fragmentation is a major challenge. At least in the health department, different donors are supporting and trying to improve the situation, but in other areas, there are very few initiatives or they have not even started. So the health department, we will open the way to other departments as well. Yeah, thanks, Pendo. And I think we would we share your optimism in recognizing that at least in the health sector, we're sort of making some progress. And I said one example of that could be this health interoperability layer in Zanzibar and other places. But certainly in other sectors, there is a lot of fragmentation as well, which is a challenge for everyone. Angel, do you want to add anything on the topic of integration and sustainability? I know you've talked already about trying to sort of make open SRP the common platform for Afia Tech for Tanzania. Is there anything else you'd like to add in response to George's question or Pendo's comment?
Yeah, thank you. So yeah, to get to George's question on the convincing the government, I think what has been influential since started these programs was using the human-centered approach. I think this was very, very key because during the designing of the architect system, for example, the other system in Zanzibar, I think we've been involving the government since day one. So they've been part and parcel of the development of the system, testing, and also taking lead in terms of even training the users themselves. So we've been participating in together with the district team, with the government in these progress meetings. So we invite them through a number of meetings. So they are very much informed on what is going on within the program side. So because of this, then the uptake or the acceptance of this integration is something that definitely they see, and they need definitely to have this system being integrated into the other government existing system, because they've been part and parcel of the implementation of the program. I think that's a contribution. Thank you, Tracy.
Thanks, Angel. Just checking if there are any other questions coming in from the audience. So yeah, we don't have any more questions, and we have just a few minutes to go, but I think we just take the time maybe to wrap up. And so I'll say thank you again, Angel, for presenting about the work of the Afia Tech project, which is a joint project between Apoteca and D3 International. Maybe as well, not everyone's aware, but we originally actually had a different speaker scheduled to do that presentation, but unfortunately our colleague Naima, she had a last minute emergency to deal with, and so Angel stepped in at the last minute. We're very grateful to you, Angel. Also to Dr. Salim Slim, Director of Preventive Services from Zanzibar Ministry of Health. We're very grateful to him as well for taking some time to share his thoughts with us about the Zanzibar Ministry of Health perspective on data use. And then thank you to everyone in the audience for joining today. I think we will close here. But just if you would like to sort of find out more about our work or our projects, then you can of course go to our website, D3 International, that's our organization's name, or Apoteca, which is Angel's organization, and find out more about our programs. So thank you everyone for your participation. Enjoy the rest of your day and enjoy the rest of the Global Digital Health Forum. Thank you.
Thank you, Tracy.